Okay, good. Hi, guys. Nice to see everyone in plain clothes. Good. All right. So I was asked to talk about some big procedure stuff that we do in the trauma bay, and really, what I hope to touch on most in talking about this is what we do when we don't exactly have what we need, or someone is asking for something specific and you're not sure exactly what they're looking for. The whole idea of this presentation is just to go through what we typically need, what might be supplemented, and when to say, you know, we just don't have that, or when to know to get a different tray, because maybe there is a different piece of equipment that you can get out of a second tray that we know is already stocked in the trauma bay. So, general emergency procedures that we see in the bay. This is going to go funny. Okay, so I'm going to talk about intraosseous access, which in fact, you know, you guys can place it just as well as we can place it, and it's actually quite simple. And I don't know that we use it as frequently as we could or should. So I hope that, do we have one here today? I don't know where Stephanie is. Okay, cool, yeah. So I really encourage you to just sit down and like hold all the pieces. There are only a few of them. I'll go through it. And it's actually incredibly straightforward and simple, but very easy to make it look really difficult.
About the IOs, is there any chance of getting radiology to allow us to do scans with contrast with IOs? Because that's our issue, is that we put an IO in, we want to do a CAT scan, they're like, that's not in our protocol, we won't do it. So then you have to bring them back up, and try to get a peripheral ID, or put a central line in to bring down a CAT scan.
So the issue with IOs is that the rate that they flow is a little bit different. And in fact, it will affect the quality of the scan that we get from radiology. So if we're doing anything with contrast, they're not ideal for that. But they're great for resuscitation. So we'll talk a little bit more about indications as we go through here. So we'll start with the IO in general. I'll see what happened. Huh. All right, so this is not advancing quite right. That work? Okay. So can you guys still see that? Mm-hmm. Okay. So so when can we use IO? So anytime we can't get access, you've got one person on either extremity, and your attending starts talking about doing a saphenous vein cut down. Do we need to do saphenous vein cut downs when we have IO access anymore? Which is faster? IO. Right. So we get really excited and we're trying to get access, and we've probably been distracted for a moment because we thought you guys had it under control because you're really good at it, and then we turn around and there's no access and we panic and we start pulling out stuff to do a saphenous vein cut down. What can you suggest? Right. And you can even place it yourself. Okay. So so the flow rate, you can do up to 5 liters an hour. Anything you push through it makes it to the heart in about 3 seconds, so good for resuscitation. So this is for patients in extremis where you don't have the time to get IV access and everyone's panicking because you don't have IV access. Well, we have a tool and we should use it, okay? You can place it in a number of locations. However, for adults, the humerus is a recommended location. In kids, it's this pre-tibial space here, just below the knee. I'll show you how to do that. But you can actually place it in a couple other spots. The medial malleolus down by the ankle is an option, and in children, the distal femur, not adults, just children. So when you open the kit, this is what it contains. You have the driver, which actually has a magnet, and the magnet attaches to the needle. I have been foiled in one trauma where someone, didn't realize that you could even do this, but the needle went inside and the plastic bit was sticking out and there was no needle sticking out, and they said, I don't even know how to drive this, there's no needle. You can put it in backwards in some of them. I don't know about this one, but word to the wise, if there's no needle hanging out, it's either you have a broken piece or you need to just pull it off because it's magnetic, right, and flip it over and right side out. Okay, first step. So there are 3 different sizes. The pink, panic. Pink is for peds, okay? So unless they're peds, don't use the pink. The blue is typically for the tibial. The yellow is 45 millimeter. That is for your humerus. It is also for people who have a little extra space between their surface and the tibia, okay? So if you have somebody who's really deep there, you may need to use the 45 millimeter. How do you know? There are little markers here, you see? There's a little 5 millimeter marker. If you bury this thing in the skin and you hub it before you actually go into the bone, you're not going to get into the marrow. You're not going to be able to use it. So if someone's placing this, the skin should be here, okay? So that you have a distance to continue driving down into the bone. And then there's, you've got your a system to hook it up, and then this is a little dressing that fits right around it. So, okay. So for the humerus, you're 1 finger breadth above the surgical neck. So the surgical neck is just the narrow point on the humerus. You literally can sort of march your way up. You sort of walk your way up until you hit the point where it starts to get wide, and then you're going to go 1 finger breadth above that. The angle is fairly important. So you want to be perpendicular to the skin, and you're aiming actually sort of at, they sort of show it here. See, so you're sort of from anterior to posterior. So you're actually aiming toward the scapula posteriorly. Make sense? Mm-hmm. Okay. All right. If you go into the tibia, and see, so you're actually angling down and away from the knee, okay? And I've heard this described a couple different ways. One is 2 finger breadths below the patella, but it's actually really the tibial tuberosity, so you feel that peak of the tibia there. It's a finger breadth below that, okay? And that angle is important. What you're doing with this angling is trying to avoid going through the growth plate, particularly in a kid, okay? And then, although we use them less commonly, just know that you can go in the medial malleolus, and you can go into the femur in peds only, okay?
Is there a growth plate in peds though?
Yeah, but again, see, if you look at the angle that they show here, you're going into this big area where you're going to have all, bone marrow access, but angling away from here. The growth plate is actually sort of right in here. So you're actually angling away from the growth plate.
Is the humerus on the front of it?
Yeah, so you're a little bit anterior, and you're aiming back toward the scapula.
And not below the shoulder? I mean, I don't know this narrowing part.
Yeah. So the easiest way to feel it is actually, and you do this with a patient as well, arm across the belly in resting position, and that actually moves the ligaments out of the way so that there's a sort of a bald spot in between where you have more direct access to the humerus. If you feel, it's a little hard, especially if you have a well-developed deltoid, to feel it. It's also why it's a longer needle, because there's muscle there in the way. But I actually find it's easier if I go from above down rather than from below up. But there's going to be this, like a bulb, and then it drops off, and you're going to go just above that, but angle down and toward the scapula. Okay. When you do this, sorry, I don't have one with me. So the steps of it are that you pick your needle size, you can push down on the skin where you're going, estimate that the needle is going to be deep enough that you can get into the bone, okay? It's a magnet, it just pops on, and you pick your location, you prep the surface. You can do it in an awake patient. There are actually lots of videos on YouTube. You can watch people have it done. The humerus is described as sort of like a paresthesia-y kind of feeling. You get kind of a zing when it initially goes in. Of course, just like with any needle, there's a little pain going right through the skin initially. But when it actually meets the bone and goes in, it's more of a pressure feeling, and it is tolerable. If people are really freaking out, you can give some lidocaine at the site to give them some anesthesia before you do it. However, you don't need to do that. And typically, right, we're going to be using this in someone who's an extremist. Just put the thing in, right? So needle, magnet, locks on. Then you pick your location, you adjust your angle, prep your skin, adjust your angle. You go into the skin, you bump the bone, you know you're there, and then it's just like if you ever used a drill or actually fired a gun, it's the same concept. It just has a trigger and consistent pressure, and you're going to feel it give way. And when it gives way, that means you're in. You take off, you hold the plastic bit stable against the skin, you take off of the driver, and there's actually a cannula that you pull out. So when you pull that out, then you have your direct conduit, and you put your extension tubing on. That tubing should be flushed before you put it on. You actually have to flush saline in, and you need to flush a good amount of saline. I would flush at least 10 cc's, and it requires a little pressure. That can be painful if you do it fast. If you just apply consistent pressure and do it slowly, it is more comfortable for patients who are awake. But you need to push a considerable amount, 10 cc's, sometimes 20 cc's, to really break it up a little, because there's a lot of fibrous connections inside that you need to sort of break through to get it to flow smoothly. And then when you draw back, nice and slow on the drawback. Anytime you hang something to go in through an IO, it needs to be in a pressurized bag, because you're overcoming the pressure differential in the marrow. If you don't have it on a pressurized bag, it's not going to flow. Questions about that? You guys are going to go over it again later.
You can also place it on the sternum, right? I think.
You can place on the sternum, though I actually have never done that, because with the sternal ones, yeah. I think it's just
I've seen like a humeral one, and there's like I've been to one of the IO cadaver labs where they have a saphenous vein cut down, and I mean, as soon as you're flushing into a humeral IO, you can see the saphenous vein. Like, I don't know why you go here if this works that fast.
Yeah, I don't know. You can use the sternum, but I don't. Also, sternal wound infections are really pretty awful and gnarly. So, like in an emergency setting. The other thing you should know is it takes about 48 hours for the wound that you create with an IO to heal. So, if you try to drive it in, get it partially in, but don't get flow, if you go back in the same location or nearby, you actually will end up with it fluid draining out of your original defect. So switch sides, switch bones. Don't go in the same area, because you'll just end up extravasating whenever you're trying to inject. So we talked a little bit about this. So when can the IO be used?
Anytime.
Right? Anytime you can't get access. How long does it take for the average resident to put in a central line? Long time, longer than anybody wants to wait, right? IOs are easy. They should be removed as soon as you have access, but they're low risk, high yield. You can place them. If you don't feel comfortable placing them, that's fine. Suggest it to the people standing there who are starting to pull all this stuff for a central line, saphenous vein cut down, and panicking that they don't have access. We forget. Okay, so saphenous vein cut downs, if you need to do that, what do we need? So, I have like extra slides here. Okay. So we used to do it all the time, but now we have IOs, which is why we don't do it as often. But we actually do saphenous vein cut downs. I've seen more times in this trauma bay than I've seen the IOs. So again, I will pitch for the IO, because this is actually a procedure, and it's actually not so easy to do if you don't do it regularly. So I've seen it a few times. At any rate, so you guys are chatty. All right, so what do you need to do it? A knife, right, would be good. A hemostat or a Kelly clamp. So everything you need to do the saphenous vein cut down is in the lac tray. All right, so usually, people are going for like the bedside tray. Is this the lac tray?
No, I don't know.
Oh, we don't have it. The lac tray is just the little tiny thing. So the little tiny thing has everything you need to do a saphenous cut down. So it has the hemostat, it has some little retractors, it has, whatever. So forceps, fine. So you can use that. So instead of busting open one of these trays, you don't necessarily need to do that. Just hand them a lac tray. They'll be fine. And a knife, okay? Sometimes they'll ask for some retraction, especially if someone is obese and has a lot of adipose tissue there. Then you might use something, oh sorry, this is the other, I'll come back to that in a second. So, it's like doubling my slides here. Okay, so these are different instruments that people might ask you for while they're trying to get the saphenous cut down. And some of them we have in the bay and some of them we don't. So vein retractors we do not have in the bay. They're very nice and useful. They're not necessary. Army Navy, that is actually in your bedside tray. Recess tray?
Okay.
Bedside recess tray. This is an
Okay.
Army Navy, okay? Really useful, a little wide, so if they didn't make a big cut, they'll complain about it, but they can use it. It will work, okay? Also in your recess tray, which may be easier for them, are these little tiny ones. So they look like Army Navies. They're similar, but they're much smaller, and they have little rakes. This we call rakes, these little fork-like things, to actually do the retraction. So if these are actually in your recess tray, I've opened these before where these weren't in there. So this is the other part of troubleshooting, right? Because we don't know what's in our tray really till we pop it open. And sometimes in central supply and cleaning and stuff, things don't make it back. So sometimes a little too big, a little too generous. If these are available, they're great. And sometimes just having a second set of hands, so if someone else can throw on sterile gloves and we use a forceps, the person who's doing the incision and dissection can use one, and someone else can assist on the other side to help retract the tissue. And that works just as well. You just need to know that it's okay to throw on some gloves and give a hand, okay? All right, so back to my previous slide. What's that? Uh-huh. And what would we need that for with the saphenous vein? This little guy. So we don't need an angiocath, right? We can take, we're going to put a silk tie around the proximal or the distal end of the vein. We make a little incision. We cut the end of this off at an angle, and we actually slide that right into the vein and tie it down for our sport, and then we can go direct connection, okay? Again, flush before you throw it in. That would be best. Okay, so sometimes the veins are too small for these, in which case the angiocath will work better, but just know they're going to be yelling at you for this. So where's the connector? Where's the tubing?
You want a connector. You don't. And I've gotten stuff from L Center where they sewed it into the veins and there's no break point.
Yeah.
So you're like, oh, great. I'm going to get lots of fluid and I have to be very careful because lots of air will get in.
Yeah.
Because they use like old tubing. Yeah.
Right.
Or even Mexico, they sew them in and there's no break point. The small point of the K50 is there's a break point.
You guys you all know what this is. We don't know what we're asking for, but you know now what we're asking for, right?
Who takes those out?
We would take them out. Yeah, because especially once we throw that in, 'cause that's a pretty large bore, and we're gonna have to stand there for a while. And we've done a procedure, so yes, you certainly can. I would recommend they have a resident come and take it out. Mm-hmm. They don't place NG tubes here. They can take some time to come and help you. That's how I feel about that. Femoral cut downs. Very rarely done now. When might we need to do this? When there's a new thing on the market that we've been using. Yeah. So like we have ultrasound, right? We're not going to really do this. However, if someone has really crappy arteries, right, really heavily calcified, we may run into trouble getting that REBOA in. In fact, particularly dilating vessels that are really atherosclerotic and calcified can be extremely challenging, and sometimes we need to get a better grip. And this is how we do that. So the femoral cut down, not dissimilar to the saphenous cut down, you just need a knife and a hemostat and some silk ties. The retractors may be more necessary in this realm, particularly because there tends to be more tissue between the surface and the vessel. But in general, it's the same concept. The other thing too, if the patient actually, in the REBOA setting, the patient's pressure is going to be profoundly low, right? So they may not be bleeding briskly from the surface. If there's some other indication for this and their pressure is decent, you may need some suction here because this may be a bloody mess. So, having a pack of 4x4s and some suction nearby, and maybe a little thing of saline so they can splash it to see what they're really trying to look at, may be helpful. Again, same instruments are useful. This Wheelander is like the most wonderful little instrument because it's a self-retracting thing, but it's not actually in any of these kits, and it's something that I can imagine, and I have heard people ask for in the bag. Yeah.
We should have
It's not here. So it's something that maybe we could add, or in the sterile kits, or the sterile.
We have a door, they should be in there.
It's
Okay.
separate.
Okay, yeah. So those are really useful, and it makes it so that one person can handle doing the procedure and not have to call somebody else for a second set of hands. REBOA, you guys did already talk about it? Gonna talk about it. Okay, so just in very brief, some of this is just logistic stuff. So what's the indication for the REBOA? The literature says below 70 millimeter mercury systolic pressure. So this is for patients who have thoracic or abdominal trauma with exsanguination, or if they have a really proximal extremity bleed where you're having trouble getting control. You can't put on a tourniquet, you're trying to compress, but it's not working. You know, this may serve a role there. Some people say below 60, and it's sort of, user dependent a little bit. The instructions are on the wall of our cabinets, our storage cabinets. So because you're going to be standing watching somebody do this is super important to help remind them, because we place these how often? How many times have you seen these placed? Right, okay. And as you might imagine, with the lack of frequency that we place them currently, and they're relatively new, people will maybe not be as adept, facile at doing this, and may be second guessing themselves. So having some basic knowledge about how they work is really helpful for someone who's trying to place them, because you can help remind them, oh, I thought maybe you meant to measure to the sternum, not to the umbilicus. Or maybe you meant to measure, to the xiphoid or to the sternum, right? I participated in placing one of these where we were low, right? And it results in actually pretty substantial trauma. You create a new defect in someone's vessel that wasn't there before. That's not good. So, this little tiny picture here. So the locations, there are 3 zones that you can place it in. You'll go over it more in detail this afternoon. But just know, safe zones that won't affect the iliacs will absolutely divert flow back up centrally, and in case anyone has bleeding in the abdomen, pelvis, or proximal lower extremities, is if you measure the balloon from either the xiphoid or the sternum. Sternum is going to be high, right? That'll be above the renals, but to the xiphoid is above the bleed, but should preserve the renal flow. Okay.
Do they measure it, just lay it outside?
So you literally take it, okay, and mark it with a finger and slide it in. It is all done by Seldinger technique, right? So just like we place a central line, and the balloon inflation is actually pretty small. So the balloon is big, but the amount of volume that you're putting in is quite small. Somewhere between, 10 cc's is probably about what you need to put in to insufflate this thing. The only time you're using more than that is somebody who has a AAA. So, yes, some of our patients may have that, but the vast majority of patients who are coming into us will not have hugely attenuated aortas that require a ton of fluid. So if someone is asking for another syringe, right, because the pressure is not correcting, right, so when you place these, people are hypotensive, you inflate the balloon, and you should see the pressure improve. If the pressure doesn't improve with the first 10 cc's and they're asking for another syringe, it's not unreasonable to say, at what level did you place it? Are you sure it's high enough? Because what can happen is that they're in the right iliac, right? And they're not getting an improvement in the pressure because the left is still open and they're not in the aorta. So just, help people troubleshoot. It can be really, really useful, right? In terms of an emergency situation where people are panicking and saying, oh, it's not working, hand me more. Okay, always question, are we in the right place? So that's all I'll say about that. And it is located top left. Okay? All right. Next, we have nothing. It's not going. Stuck. Chest tubes. One of my favorite procedures. It's so satisfying. Okay. What do we need to do with a chest tube? What do we need to relieve the pathophysiology that is affecting our patient when we're placing a chest tube? Okay.
The physiology.
What do we actually need to save the life of the person who has a tension pneumo or tension hemotherapy? Okay, so a needle, or we're in the trauma bay and have the resources. A blade. No, it didn't do it. It didn't do it. I've got. Did it do it? Okay, good. All right. Good. Yeah. So the reality is, people are like, oh, we need to place a chest tube. Where's the chest tube? Hand them a knife. Push them toward the patient and say, okay, go. Because that's all you need, right? It's all you need. And so while everybody's getting ready, getting the Pleurovac, which we didn't expect we would need, getting the chest tube of the right size, irrelevant, right? Knife. That's all you need. And they'll be yelling for the Kelly. You can actually cut down through the intercostal muscles on the rib. You will not hit any major vessels by doing that. You will get into the chest very quickly, and you will relieve the tension physiology that is causing your patient to die. Okay. Other things that are nice to have once you get things settled down, right? So hopefully they're already wearing their gloves. But, skin prep, drapes, all this business. If you have somebody who's really interested, just like we do with a left thoracotomy, you throw some betadine on and you cut them open. It's just the way it is. It's okay, and you're saving lives. It's fine. Additional things that are useful, Kelly clamps, lidocaine if they're awake, chest tube, and the Pleurovac, okay? And we try to use a bigger chest tube, particularly for hemothorax, right, so it doesn't clot off. Just know that there is a lot of literature that supports just doing these as pigtail catheters, right? So the largest bore isn't necessarily the only thing you can use, and so at other institutions in particular, you may see that in practice. Here we still use pretty large bore tubing. Okay. Pleurovacs. Do you guys all know how these work? Yes? I don't need to go through it. Everybody knows about the 3 chambers and how the 3 chambers work? Yes. You guys already did this. Okay, fine. Done. All right. So, it wants me to show it to you. Okay, so that one's full. Sorry, this is not going. It's panicking. Okay. All right, yeah. So basically, you have the 3 chambers, right? One fills with fluid, lets the air through. One is the U-pipe like you have in your toilet that prevents you from dying from toxins in the sewer. This prevents the patient from having backflow of air, causing them to have a tension pneumo. Same concept. And then the last one's the pressure differential. So if it's not at 20 centimeters, is the pressure adequate, that differential? No. So you refill it at the bedside. You're checking it daily, right? Okay. Left thoracotomy, my second favorite. Maybe my first. Okay. Except it always portends bad things, right? So who gets a left thoracotomy?
Dead people.
Yeah, dead people, right? So is there any benefit for the patient? This may get me in trouble, but we're on recording, so I'm going to say it anyway. Is there any benefit to the patient if they meet the criteria for a left thoracotomy to wait for the attending to walk in if there is a fellow or chief resident at the bedside?
No.
Right. Patient is dead, right? Patient. Well, so this is an important question, right? Because people will say, whoa, where's your attending? The patient is dead, okay? And I, as a fellow, have been delayed, not in the trauma bay, have been delayed in doing a left thoracotomy because the attending wasn't present. Be careful, because the patient's already dead. So if we're going to save them, either the attending shows up really fast, which they're planning to do anyway, or we don't do this, right? Because what's the time frame where it actually helps? Right, so the sooner the better. If it's penetrating trauma and they lose vitals witnessed, right, and their CPR is less than 10 minutes, then there is some benefit. If it's blunt trauma, it's probably less. And what are the chances that people survive with blunt trauma, witnessed arrest, and a left thoracotomy? Right, extremely low. But this is it, right? Either they're dead or this works. And that's it. That's really all there is. And what do we need? A blade, right. So that's the physiology. The blade is, so I would argue, okay, so the blade is the most important part about getting into the chest. But once you're in there, what else is really useful? Right. So you have to have good retraction. you may need suction, but if somebody is in extremis or dead, right, you're not going to have a lot of bleeding, so that probably actually won't be a big deal. It's more about sweeping whatever's already in there out of the way. Light is really useful, and so in the trauma bay, obviously, right, we don't have great light. So someone may be saying, I can't see crap. So if you have your cell phone or something that can help illuminate that space, or a flashlight, that may actually be necessary at the time.
We took those big lights up and they burn out. They
Yeah.
burn out.
Right. So if we have a big light, awesome. If we don't have a big light, be resourceful. And most of all, when someone's doing it, they may very well need your assistance. One, they're going to need your assistance to help get light so they can see what they need to do. Two, the finished shadow is probably not assembled, / probably broken, / they're trying to get into the chest. So if somebody else has a set of sterile gloves, right, you can help get things ready so that they can get in. And in fact, so we tried to get the ones that are already assembled, right? And we have a couple of them, but these are still floating around. So just preparing for this course, let me show you what I found. All right. So which way do these go?
Out? Yeah.
Curve facing out, right? Because they're going to tuck under the rib, right, to do the retraction. Okay. Now, to assemble them, they've got these little holes. So these things just slide over the top once they're already on to kind of keep them in place. All right, cool. So, Oh no, it's not just that I'm not putting it in the hole, it doesn't fit. Hey, okay, so this kit has pieces that don't fit. Okay, so don't panic if it doesn't work. It's not you, it's the kit. Get another one, okay? All right, so we move on to ones that might work, okay.
And then you're showing that one that's already put together.
Right, so this one's partially assembled. This is correct, see this? So out. So these splay out, and there should be 2 of these, right? Okay, so we put this in. They slide in to place, and then these slide alongside it. I encourage you guys to actually practice, like just try this. It's not that you need a lot of practice, but just to try it, right? And this one actually won't even slide down. Okay, so this one's not working well either. However, my guess is that it would actually be adequate for us to do the resuscitation. Okay, fine. So when we put this on, is it like this?
No.
It's like this. What's in the way?
Shoulder.
My arm, the lead, which if I tear it with this, now is metal to metal conducting. People actually get big burns in their axilla. So if you have someone come in who's crashing, don't throw a lead right here. You want to throw a lead right there because it's open and available. And it's on the side and you're like, oh, it's out of the way. Not if we're doing a left thoracotomy, it's not, it's right in the way. Also, when you're doing chest compressions, which side do we do chest compressions from when we're deciding whether or not we're going to do a left thoracotomy? Right. Because otherwise you're going to get cut. So don't stand there. It's a terrible place to be. So, and there's no point in doing chest compressions if the patient's exsanguinating, right?
Right.
You got it in the chest.
Volume.
Okay. Good? Makes sense. Okay.
We
So
wear sterile gloves, like if
You're going to resuscitate
so throw on sterile gloves. It's not a clean procedure, right? We just threw betadine all over the patients, dripping on the floor. But it's the difference between life and death, right? And the patient's already dead. So the only thing we can do is help or let them die, which may happen anyway, but we're making best effort, okay? Yeah. Yeah, so if your chest tray doesn't seem to be assembling, don't panic. We know we have more, right? There are other ones in the bay. So get the other ones. Oh yeah, this just,
So how did I got it wrong? I put one on and then Kobayashi said it's backward.
so backward will be this. So see again, they curve out. Curving out, okay? If they curve in, they don't hold on to anything. So they have to curve out. So that's what, they'll be like, oh God, it's backwards, and they'll take out their hand and they'll be fumbling. That's why.
Doesn't the resident know how to put
They don't, because they do this less frequently than you guys see this, right? How often do they get to see a left thoracotomy? Once a year, once in an entire 5 years of training, maybe, yeah? So, and they're not going to see it. So you guys are the best eyes and ears to fix it.
We have open chest trays and then we have the retractors and the different things.
Right. So,
No, we have
well,
extra.
okay. Yeah.
So there is a finish in there.
Yeah. So this chest tray, I don't know if this is the full one or not, has like a bunch of other stuff. So I'm going to show you the other stuff that's useful. Slide. Okay. So where it's located, right? Open chest tray. Okay. So there's their finishetto, and you can see down. And then you're going to have the crank down on the side here. All right. Okay, so then they start yelling at you, oh, the side biting clamp, I need the side biting clamp. And you're like, what the hell is that? Okay, great. So how do you get to the aorta? Okay, so there are things you need to get to the aorta, right? So you have a couple of different things in here. One, you need something that can dissect. So this is a large hemostat. Okay, it's also, this one actually is truly a DeBakey clamp, so it's smooth on the inside, so it won't actually tear the aorta. But you can actually use this to dissect, because what they're trying to do is to get an opening above and below the aorta right against the spine. So you can't see well, right? And a lot of it's by feel, and you're trying to dissect that space. It's really hard. The last time I did it, I actually had to just tear it open with my finger because someone handed me something about this size. Because we were, you know, we were in duress. Okay, can I get into the chest with this? Where is my hand now? All the way in, right? And I can't see what I'm doing, and I can't dissect, and it's not going to work. So long instruments are the best. You can actually use the DeBakey clamp. This is the cross clamp that you can put across the aorta. You can actually use this to dissect. Sometimes it's really hard to do that, and so they may ask you for a side biting clamp, which is this guy. This is a Satinsky. There's actually, this is another version, a Lambert K, which has a little angle on it that makes it nice. But basically, this thing, so if the aorta is like this, we're putting this in and coming across it like that. And actually, this is easier, because you can almost come directly on it. Okay, so I know there are a number of attendings who prefer this. Kobayashi is one of them. Kobayashi knows her stuff. I like her very much, and that's why I actually started using this after working with her, because I find it much easier than using this. So they may ask you for that. Either of these will work, and if you have your gloves on, you can help hand things off, because the residents may not know, probably won't know, okay? And you will be a much better resource.
Is that on the open chest tray?
Yeah, so it's on the open chest tray. It's actually, so now I've looked at a few of these chest trays, it's on all of them, so we can count on it being there. Okay. The other thing too is these Army Navies. So say there's a problem with the finishetto. I have had cases where people couldn't get the finishetto to work or whatever. We're still in an emergency. People can actually do some manual retraction. It stinks because your hand's really in the way. But if you need to, so be it. The Army Navies can actually be used to provide some retraction, or toward the mediastinum to elevate the, get the lung out of the way, get better exposure. Maybe there's a cardiac injury and someone needs better exposure. So these can be used as well as the rakes. So I showed you like these little tiny rakes, right? There are big rakes as well, and they may be useful. And sometimes people, instead of just using a knife to get all the way through, are using some big scissors, right, to get into the chest initially. So it's actually very hard to be doing the left thoracotomy, trying to get into the chest, and then get the instruments you need. Most surgeons, right, or all surgeons, are used to somebody handing them an instrument. Mm-hmm. So in that setting, it's really challenging, and you'll hear people yell, just bring the tray over here, just bring the tray over here, because when they ask for something, nobody knows what to get them. So if you familiarize yourself with these instruments, it will be hugely helpful, and we can all try to save the life that is already lost. Cricothyroidotomy. So we don't do these very often, right? But when might we do them? Yeah. So these patients have an airway issue, not a perfusion or circulatory issue, so they bleed, right? And we know that. So what's really useful in the setting of doing this? Suction, right? Which often isn't set up. Well, it should be set up right, because we're actually doing an intubation that fails. But sometimes that's not what's happening, right? We're not actually intubating yet, and all of a sudden we realize the patient doesn't have an airway, or they're being transferred bed to bed, and respiratory is just getting there, and whatever. Suction, suction, suction. Okay, great. So severe facial trauma, impending airway loss, airway obstruction. So this is how it's different from a standard trach. So in children, actually, we advocate for doing the trach. Long-term outcomes are better for kids when we do that. So that's below the cricoid cartilage. In adults, we're going to go through that cricothyroid membrane. Why? It's an easy landmark to find. The trachea is not particularly mobile there. We can get a good grip on it. We can get good exposure. We can go. Okay. What do we need to get in? I would argue, oh, it doesn't like this one. I made a mess. I broke this, guys. I'm sorry. So I would argue that actually that's so frustrating. It's trying to play that animation of the blade swinging in.
So you keep saying 15 blade. I remember we have only 10 and 11.
That's right.
So that's fine. Okay, so that's okay. No, that's a good question. So yes, you can use an 11 blade.
Okay.
You could use a 10 blade too.
Okay.
It's really, maybe the more important thing is when you hand it to somebody, tell them what it is, because it makes a difference how you use it. So in an emergency, when they just go to, at least they know what's in their hand. No, it really didn't like this. Looks like it. Yeah. So the 10 blade has a curved edge, whereas the 15 blade's a little bigger than the 10, and the 11 blade is just like a triangulated sharp blade. So it's used in a soft fashion, where the others you use the belly of the blade to get in. So
should we get 15 blade?
well,
They are.
it's a
They're on the part.
yeah. So for so if we're doing the thoracotomy, using the 10 blade or a 15 is better, right? Because you can use the belly of the blade to get in. Oh, that's okay. We can do it that way.
We wrote like 10 chest on it, but then they said,
Then should be on the
soak through. Never in the trauma.
Have I I am over my time also. Okay. I'm almost done. Sorry guys, I'm over my time. All right, so I would argue that the 15 blade's important, but what's actually going to establish the airway, unlike doing a chest tube, unlike trying to get into the chest and attention pneumothorax, you're trying to establish an airway. So if you don't have something to stick in the hole that you're making, there is no benefit to doing this. So having an ET tube nearby is really important. And if you don't have an ET tube and you have some other kind of tubing, you can use that, but we're in the trauma bay, we should have a tube, okay? And don't, someone might ask you for a tracheostomy tubing. You don't need that, right? You're not going to put a trach in an emergency setting. You're just trying to get an airway, and actually it's better to use use an ET tube, because you can actually drive it down a little further, secure it. You're going to be moving the patient around. ET tube. And you need a smaller one probably than if you're doing an oral airway, right? So instead of an 8, you might need a 6 in this setting.
Do we have the sizes?
We do. We do. You want the biggest tubing you can, but the reality is that you don't know what you're in for, and you're doing it emergently, and so anything is better than nothing. So having both of them available is great. If you only have a 6 is great. If you only have an 8, I would be a little worried, honestly.
We have 6 now.
And they are all there. So, but if you hand them an 8, know that the next thing on your mind should be, do we have a smaller tube? Okay. All right. Okay. Knife and tube. Okay. And some suction, really good. And the retractors, just the resus tray at the side of the bed that has all the retraction that you need. There's also the dilator. So that's where the cric tray lives. There is one in there. Let's see. Yeah. So this thing. Sorry, I have too many slides. So this is the dilator. It's rounded on the sides, and you squeeze it, and it spreads out like this, and it'll actually spread the trachea open so we can get the tube down in. You don't necessarily need this, but it can be helpful. Okay. That's the end. Sorry, that was really long. Questions? Good. Other questions about stuff?
I was just saying to the other people that they're not disposable, these instruments. They have to be.
Oh, yes. Yeah, so they need to go back to sterile so that we can get them back for the next
So can we
time.
ask them why everything's not working in those?
Yeah, I mean, so that you know, this is not unique to the trauma bay. It's not just that they're giving us ones that aren't working. It is a universal issue because these are reusable instruments. The people who are doing the sterilization are supposed to check everything before it goes into the kit. But, you know, they aren't the surgeons using them or the scrub techs who are using them. And so sometimes, you know, that level of oversight and or understanding that it's broken may not be there. And sometimes accidents happen. So the unfortunate aspect of this, right, is that we don't know that the tray is broken or doesn't have enough pieces until you pop it open in an emergency. And so the real takeaway, I think, today is that we have multiple kinds of trays. There is a lot of overlap between the type of instruments you need to do all these various procedures. The resus tray has the basics for almost all of them, and the only thing that's truly outlying is the finishetto. That's really the only thing that can't truly be replaced. Although, if we don't have
I
one,
learned that you guys don't have to have any specific instruments. You can make do with anything.
Right.
Right?
right? So that's what I'm saying. So throw some gloves on, stretch it out, whatever retractors you have, because time is of the essence in that case. So while we're fumbling around and people are like, I need the finishetto.
Just hold it up.
Yeah, throw some gloves on. In that setting, guys, throw 2 sets of gloves on.
Right.
So, you know, you'll see we only throw 1 set on. That's a terrible idea. So not only, you know, can you be cut, but the ribs crack, and there's a lot of potential for things to be torn and cause you injury. So just be very careful when you're assisting. But it's okay to do that. I mean, get right in there, because the more help we have from someone who is comfortable doing so, knowledgeable about it, able to help facilitate, the better the chances are for the patient and the safer it is for everybody involved. So,
Cool. Thank you.
cool? All right. Thank you, guys.